This is Shoshana from CIBHS. Welcome to the Small County Fiscal TA webinar with Mike Geis. The usual stuff, you're all on mute. If you have questions, please type them in the question box or click the hand icon to let us know you have a question and we can unmute you. Next webinar will be May 19th, and that will be the last one for this fiscal year. Hopefully we will be able to continue them in the next fiscal year. And I think that's really all. And I sent the PowerPoint this morning, so if you didn't receive it, try to email me now or after the webinar, and I'll send it to you. And with that, I'll give it to Mike.
Great. Thank you, Shoshana. Good afternoon. So what we're going to cover this afternoon is primarily what was discussed at the April 7th Services Committee meeting. And now, actually, it's kind of interesting looking at this title slide. I really need to change that. It no longer is mental health. We're really now discussing behavioral health fiscal issues because we're getting into a lot more of the substance use disorder financial issues in addition to mental health. So I'm going to do that in the future. You can see the outline of what was discussed at the meeting there. And so we'll go through each one of those. And so kicking it off, we had an update from the metrics work group. So for those of you who aren't familiar, this is a work group that was developed in response to CMS's special terms and conditions as part of their 1915B waiver approval. They wanted to have the metrics displayed and monitored and measured and benchmarked. Really, I didn't hear much new on this at the meeting, other than a couple of things, primarily that they have these four new indicators around wait times, the date of the request for service, the offer of service, the schedule for service, and then the actual, I guess, receipt of service. So it really is looking at setting benchmarks around timeliness and access to services, which you would expect that somebody should be measuring of a managed care plan, because that's typically one of the areas where managed care plans fall short, is by restricting services. And so by starting to look at this, it just kind of makes sense. And it'll be interesting to see when some of these metrics get published, how you all look in terms of wait times and those sorts of things. And so they've got this I guess this web page that will provide for public access to the different dashboards that they're going to put together. We'll identify correct. We'll publish the EQRO data, and we'll provide links to your quality improvement plans so that it kind of gives place for any stakeholder to go and see what's going on in terms of access to services. Any questions on the metrics work group? All right, this next one's going to be pretty short as well, because we probably spent 2 minutes on it at most. And really, again, there wasn't anything new as far as the ICD-10 and DSM-5. They're still working on information notices. Again, there really was not anything new that they reported, the state reported. Then we got into the substance use disorder update, starting off with the cost report. And they're preparing a new web-based cost report for 14-15. At the meeting, they said they were going to hold 3 webinars on the forms, that April 12th, 13th, and 14th. Hopefully some of you participated in those webinars. Hopefully they happened, and you were able to participate and learn how the new web-based forms work. the training was supposed to be on how to complete the cost report and not really on content or strategies around the cost report. And they were saying at that point they were anticipating 2016 due date for the 14-15 cost report. I don't know if they presented anything different at the webinar. So that's the latest information I have. And then they talked a little bit about the 15-16 report. And they're looking at that because that probably will be a little bit of a shift in terms of how you report some of your costs. Hopefully, at least you're isolating administration and so forth, similar to what you do on the Medi-Cal, especially mental health cost report. And again, at the meeting, they reiterated they anticipate January 2017 due date for the 15-16 cost report, and that they may have training in August of 2016. So, any questions on any of that stuff? All right. We talked a little bit about the SAPD block grant, and there were some overpayments made. Originally, I thought they were from 14-15, but apparently, based on the title of the agenda item, it said it was 14 overpayments to counties. And they so they overpaid some counties, basically 52 counties, and 2 counties were shorted. And they've said that my understanding is current year payments will not be distributed until the 52 counties that were overpaid had returned their 13-14 overpayment. At the time of the meeting, there were 11 counties that had not returned their overpayment. And so it was really questioned why was DHCS withholding the payments for every county when, just because a couple of counties hadn't returned their payments, which could be for a lot of different reasons. So DHCS said they were going to take it back, and because apparently it was coming from their accounting shop as to why they couldn't release the current year payments until everybody returned the overpayment. So I guess they're going to get back to us on that. We talked about it a little bit in county to county as well, and the list of counties I believe was going to be discussed at governing board within CBHDA to find out either how to get this issue resolved so that you guys can get your money. And then we talked a little bit about how the early intervention for HIV, the set-aside has been eliminated. DHCS did issue an information notice 16-012, and in that notice it specifies that you have until September 30th both to provide the services and to actually expend the funding. So the funds need to be expended by September 30th. And they have said previously that, and it's basically that the state no longer qualifies, I guess, for the set-aside. But the monies will then be part of the discretionary SAPD allocation, but you won't be able to fund these specific services. So that is what's going on there. And I think the information notice was pretty brief, but it did provide some specificity around that the funds needed to be expended by September 30th. So any questions on any of that?
I'm not sure. Rose Bullock has her hand up, so let me see if Rose, you're unmuted. Did you have a question? Hello? Okay. Must have raised her hand by accident.
Okay. Moving on then to the drug Medi-Cal update. Again, nothing really new on the quality assurance utilization review claiming. It's not going to be available in the current fiscal year, so we'll have to wait to 16-17 to be able to claim separately and hopefully at the enhanced rates for the skilled professional medical personnel for your QA UR costs. The county, in terms of the county administrative claiming, this really isn't, I don't think, anything new. They said this at the last meeting that they're implementing a new process, and so they are only paying these quarterly county administrative claims every 2 quarters. So they're basically making payments twice a year. They said that they were going to pay the first and second quarter claims, should have been paid during the third quarter. So hopefully those were paid if you had submitted quarter claims. And then the third and fourth quarter administrative claims for the current year won't actually be paid, they said, until the beginning of next fiscal year. So from a cash flow perspective, don't anticipate payments on your third and fourth quarter administrative claims until next year. We talked a little bit about the organized delivery system waiver for drug Medi-Cal. DHCS held a high-level fiscal webinar last month. They, I believe, are planning for another fiscal webinar in May, the beginning of May, and that will focus a lot on the rate setting. So hopefully getting into a lot more detail, potentially even, I think, with some counties who have gone through the process, providing basically some technical assistance to all of you folks. So look for that webinar hopefully in May. DHCS said they're still negotiating the CPE protocol and the contract terms and conditions with the federal government. CMS came back with some questions, I guess, on the CPE protocol, and DHCS was responding to those questions. And I mean, for those of you who remember how long we went through with the mental health fiscal state plan amendment, this is just kind of what goes on with CMS. It's kind of a back and forth for a while until everything's addressed with CMS and they feel comfortable with what is being submitted. The cost report under the waiver will be slightly different. Again, they're probably, well, for sure, the two things above there, where you're looking at isolating your QA/UR costs and your administrative costs. I think under the waiver, there's a strong focus on your certified public expenditures, and so there may be some slight differences for the cost report waiver. Although I'm just speculating at this point, so I don't have any other information on that. They're preparing system changes for the new services, and they indicated they did receive implementations from 7 of the counties. And so maybe those counties will be the ones that will help out with that webinar in May. So any questions on the ODS?
Well, going back to the previous slide, Rose sent in a question. Fiscal did not receive an overpayment, but identified by the state should have been for fiscal year 14-15. This payment they asked us to return, and they would reissue payment with the correct fiscal year. Anyone else experienced the same issue?
Yeah, so that's, I think, the issue, that they said they wanted you to return the payment. Now, again, I originally thought it was for 14-15, but the title on the agenda for the CBHDA meeting says 13-14 SAPD overpayments, but maybe it is the 14-15 was the overpayment. They want you to return the overpayment, and then they're going to reissue it in as part of the current fiscal year distribution. But they're not going to give you that distribution. At least their policy as of the meeting was they weren't going to give you your current year distribution until every county had returned the overpayment. So hopefully that answers the question. But again, I'm not sure which year the overpayment was, whether it was 13, 14. I thought it was 14, 15, but like I said, the title on the agenda says 13, 14. All right, any other questions on basically substance use disorder stuff? We get into, all right. Oh no, I forgot we did have some more drug Medi-Cal. So DHCS, one of the audit, I guess the audit chief for drug Medi-Cal, or not just drug Medi-Cal, for all substance use disorder services, actually attended the Financial Services Committee meeting, which was great, and talked a little bit about some of the common audit findings that they see, which is what you folks asked for at the prior meeting. And so some of those common audit findings are things that they see come up in a lot of different providers are, number one, lack of documentation of the expenditures reported on the cost report. So again, you need to have the support for the numbers that are shown on the cost report. He also highlighted that, if you ask a state analyst a question and they tell you to do something a certain way, make sure you get that in writing so that when the auditors come out, you can show them that, hey, this is why you treated this cost in this manner, was because that wasn't consistent with the direction you were provided by the state. They won't accept, well, this analyst told me to do that. They would want to actually see it in writing. And generally, at the Financial Services Committee meetings, whenever we hear that a policy is a certain way or you're supposed to do certain things on the cost report, we generally ask for it in writing. But individually, if you're doing that, you definitely want to get things in writing. He also said that often the records don't reconcile with the provider's cost report. So, you've got the provider who submits the cost report to the county, and then the county puts it all together and submits it to the state. And often when they go and audit the provider, it isn't consistent with what was filed. So you want to make sure that they reconcile. Talked a little bit about cost allocation methodologies and making sure that you use an appropriate approach. And really there were two things around the cost allocation methodologies. One is you want to use an appropriate approach in that every cost center is bearing the appropriate burden of the cost. So they all get allocated appropriately across all cost centers that receive a benefit from the indirect cost center. And then secondly, which again kind of goes back to the first bullet here, is really just maintaining the documentation that supports the allocation. So if you used various statistics to come up with your allocation, then you want to make sure you have the documentation for those statistics so that you can provide those to the auditors when they visit you. He also says, well, not often, but sometimes you have the inclusion of certain costs that are not allowable. For the Medi-Cal program won't pay for food, and so you need to make sure if you've got food or any other non-allowable costs, you want to pull those out. And again, I think this primarily related to the drug Medi-Cal program. And then lack of support for the units of service, again on the drug Medi-Cal side, making sure you have the documentation to support the units of service that you're showing on the cost report. And then there were a couple things the counties asked for. One was a clear definition of indirect costs from DHCS. And really, I don't know if this as much related to the drug Medi-Cal or the substance use disorder cost report versus the mental health cost report, where it was DMH, but there's an information or policy letter 11-01 that changed the way indirect costs were treated on the cost report and reimbursed, and shifted them from administration to being allocated consistent with federal requirements. And even though you're now in these audits for these years prior to when this policy letter was written, the state does not apply that policy letter until cost reports on or after that date, or services on or after that date. So it's kind of frustrating, I know, for you folks. And then, we really want to get into consistent both approaches and standards in terms of how DHCS is auditing both the mental health side and disorder side. It should be the same standards, same approaches. Your indirect cost allocation, all those sorts of things should be consistent, especially when you look at the Medi-Cal program, either under mental health or on the substance use side, because they're Medi-Cal rules. And so the audit should be consistent. And this substance use disorder audit supervisor did say, he thought the mental health audit supervisor may be willing to kind of come and do the same thing, although I believe it's been asked previously, and that has not happened. So we'll see whether that happens. The other thing we talked about, and I didn't put any bullet points on here, had to do with FQHCs and providing drug Medi-Cal services. And he said if you had specific questions, you should really follow up with the state folks, in this case the FQHC unit, to make sure that that how you're defining it and what you're doing is consistent with what they expect. You're going to want to have a clear delineation between what services they're providing that would fall under the drug Medi-Cal program. And then we talked a little bit about, although we didn't get too much into it, Senate Bill 1335, which would allow both FQHCs and the rural health clinics to provide not only drug Medi-Cal services, but also Medi-Cal, especially mental health services. And it would take the cost of those services out of their prospective payment rates, and they would be reimbursed consistent with whatever the contract is with the county mental health plan for mental health services, or with the county for drug Medi-Cal if they contract with the county, or the FQHC or rural health center could contract directly with the state to provide the drug Medi-Cal services. So I believe that bill is still in the appropriation committee, but I also believe CBHDA is kind of keeping an eye to see where that goes in terms of whether that would allow you to potentially contract with FQHCs and rural health centers directly for both drug Medi-Cal and Medi-Cal, especially mental health services. So any questions on any of those issues? All right, then we had a brief update on the Short Doyle Modernization project. Remember, this is the project that really has a couple of components to it. One is Short Doyle 2 system improvements, and you can look at the survey results on CBHCA's website. But really, I think the main effort that's going on, or that actually just finished up, was this Fiscal pilot study where Harbidge analyzed beneficiary data from, I believe it was 5 participating pilot counties. Harbidge was going to report the results, or did report the results, to the CBHDA governing board a couple weeks ago. And what was mentioned in the meeting was just a couple of points about some of the findings of Harbidge's work. One, that there has been a significant increase in the number of Medi-Cal beneficiaries since basically we operated under the carve-out waiver in 1995. So and then also what the carve-out was based on was DSM-2 data, which obviously we're way beyond that. So one of the questions was whether a lot of the criteria and so forth that was used to establish the carve-out, whether that still is relevant given the increase in beneficiaries, GSM, to where we are now, 20 plus years later. Harbridge said I believe they were going to provide some guidance or on the next steps, but really I think that there will be a much broader discussion at the May Financial Services Committee meeting in terms of the work and the study, and so hopefully we'll hear more then. Any questions on that? All right, moving into claims payment update. The electronic funds transfer project is still going on. San Francisco is testing it. And DHCS said they're documenting the process for lessons learned and potential improvements. I would think that would help for the EFT so that you guys can get paid through an EFT process rather than hard warrants. And then we were told about what's going on with the adjudication of claims with multiple aid code project. Originally, they were anticipating the system fix to be in the next couple of months. And these would allow, this provides changes to the system that would allow for the adjudication of claims at the highest paying aid code or highest approvable aid code. Because right now, it may look to try to pay at the highest approvable aid code, but if the service doesn't qualify, then it denies the whole claim. So anyway, they're trying to make system fixes, but we were told that this has been delayed until further notice, this project, because of Senate Bill 75 implementation, which I'll talk about next. So I guess they don't have the resources to get this system fix in place by June, so we don't know when this will occur. They did say they're looking at 3 different groupings of impacted claims, those within 15 months of service, those 16 to 36 months of service, and those that are greater than 36 months of service. And there's still a whole bunch of issues that they're going to have to address. One of probably the biggest ones is, how are they going to deal with some of these legacy systems where you're no longer even operating the same claims processing system that you operated when these claims were denied, and what are they going to as support for the approval of those claims? What hopefully policy talks to the auditors so that it's really clear what they're going to accept, because it would be unfortunate to have an individual auditor have a different interpretation than maybe what their policy folks said. And then, I'm sure this is, Los Angeles brought up that, they have providers who are really concerned about this. They've got these claims hanging out there, and they're not sure if they're going to get approved, and, the liability just continues to grow. And so they really want resolution to this. So, of course, DHCS will publish an information notice to make it all crystal clear. But again, who knows the timing? So we'll just have to wait and see. Any questions on any of that stuff? All right, then moving into the Senate Bill 75. So this was actually signed and enacted, or it's in the process of being implemented. And what this bill does is allows for children under 19 to be eligible for full scope Medi-Cal regardless of their immigration status, as long as they meet all of the other eligibility requirements. And so DHCS is trying to implement the system changes by May 16th. And so that would apply to anybody who was then eligible during the month of May, so back to May 1st. There are provisions that if the state is not ready, they can delay it. So if the system isn't ready to handle, the processing of these claims by May 16th, it may get delayed. And so again, this is why DHCS isn't really looking at our claims with multiple aid code project anymore, or at least it's not a high priority. So, and really, so you've got two different categories of population under this bill. You've got some folks, some kids who are not enrolled in the Medi-Cal program at all that will become newly enrolled because they will meet the criteria, and maybe they haven't enrolled previously because of their immigration status. And then you'll have a transition population, and these are the children that are already enrolled in restricted aid codes that might not have been eligible for Medi-Cal Specialty Mental Health Services or Drug Medi-Cal services. Those will now be eligible for to receive Medi-Cal Specialty Mental Health and Drug Medi-Cal. The services will be paid for 100% with state general fund monies. There's no federal funds involved, but the state will pay at 100%. And there is a crosswalk, as well as there's an implementation guide. If you go onto DHCS's website, and you'll see it. It's right there on the front, and you can take a look through if you want more detail. But there is this crosswalk, which is now posted on CBHDA's website, that does provide a crosswalk between these restricted aid codes, which currently exist, and what I believe the full scope aid codes will be under this program once implemented. So hopefully it will just be a systems programming change for you folks, and not much else. And part of the way it's really, so the new enrollees, the state estimates that there are about 55,000 children statewide that will potentially be the new enrollees under this. And kind of the way I would look at this is almost like a mini Affordable Care Act sort of thing, where if you're already serving some of these children, this is going to be increased reimbursement for you if you can get the system programming correctly. And then ultimately, you may have to increase capacity, again, similar to what you probably were looking at or are looking at under the ACA, where initially you just continue to do what you always do and received additional money, but now you're realizing you have probably additional need, and so you would have to expand capacity either through hiring folks or contracting out more. But this doesn't seem like it's going to be huge, but it will have an impact, and I think initially it will just be a positive impact on revenue. Ultimately, you're going to have to probably step up capacity a little bit. So any questions on this? All right. Moving on to the MHSA. So we received a little bit of an update here. In terms of the 13-14 revenue and expenditure report, DHCS indicated they'd received reports from 35 counties. They're still working with, policies working with legal on how to incorporate the innovation reversion provisions that are in Information Notice 1115 into the report. And if, just to give you real quick, the Information Notice 1115 said for purposes of reversion that innovation should be looked at in the context of where the funding came from, which is CSS and PEI. And so what it theoretically does is gives you the ability to spend older innovation funds beyond the 3-year period if you don't have a CSS or PEI reversion issue. So they're now looking, their legal's looking into that, and hopefully we'll have something soon on that. The Oversight and Accountability Commission is doing a revenue and expenditure report project. They're developing this fiscal transparency tool. They indicated that they've got the beta version pretty much done, and they were going to check with counties in terms of the accuracy of the data, reflecting what was reported to the state. because again, that's what their main focus is. Is this data what you reported to the state? And their goal is to develop or improve the availability of data to the public, and really to let the public know what's going on, because you'll see various newspaper articles that'll get published saying there's all this unspent funds. This will be a way to hopefully have a centralized location that allows, again, stakeholders to see what's going on. They're also hoping, as a result of this tool, that it will identify some of the challenges and hopefully solutions to the current revenue and expenditure report. And they're really hoping to get information from you guys on, why are your fund balances high, and hopefully, you'll be able to be honest. I mean, there's several obvious ones, which are the unpredictable revenue stream. It can fluctuate by 30–40% in a year, even over what is projected. And there's also uncertainty to the extent that you're doing any Medi-Cal services with these funds. To what extent are auditors going to come in and disallow the Medi-Cal, in which case you would have to use unspent MHSA funds to cover the cost. And then there are a bunch of other issues which I would kind of categorize into sort of the government issue bucket, which is trying to hire staff. It's a lengthy process. A lot of times, especially in some of the smaller rural counties, you may not be able to pay enough to attract staff, and if you tried to increase pay, it would potentially impact other employee classifications within your county, and that could have a county general fund impact. And then you have the ability of trying to contract out staff. Often you get pushback from unions. So again, hopefully a lot of this will come up and come out as part of this process, but to wait and see. And I'm just going to finish up with MHSA, and then I'll take any MHSA questions. But and where hopefully this will come up is part of this Oversight and Accountability Commission panel that will happen at their May Commission meeting, which is, I believe, the fourth Thursday of May, and they're going to have a panel. It says to discuss reversion. I think it's going to be to discuss reversion. It'll probably cover, why again are there all these unspent funds? Are there ways to quantify what should be the appropriate level of unspent funds? And we keep hearing DHCS is drafting fiscal regulations, and so who knows if there will be something that we can review prior to that. And then lastly, it sounds like the Oversight and Accountability Commission wants to survey you guys with a short survey, just to find out what are some of the challenges in completing the revenue and expenditure report, and really get that documented, I think, in writing. They hear verbatim when they come to the Financial Services Committee some of the issues, but I think to actually have some concrete examples will be really good. So that's the MHSA update. Anybody have any questions on any of that stuff? And again, hopefully some of you will either be asked to participate or will volunteer to participate in this Oversight and Accountability Commission meeting in May.
There is a question. CBHDA sent a letter to the state requesting the RER form being changed. Have you heard anything about the RER correction?
I haven't heard anything, and actually I'll talk a little bit about that in county to county, but bottom line is I haven't heard anything. Okay. All right. Moving into the state and federal budget update. So some good news, at least I thought was good news, was it sounds like, so if you remember in the prior meeting when we were talking about the behavioral health subaccount with 2011 realignment, the state was actually considering changing the allocation percentages for the current fiscal year, even though we're 3/4 of the way through the fiscal year. So what was brought up at this meeting is that they, at this point, are not looking to change the 15-16 allocation percentages. So for me, I thought that was good news. So at least you can continue to plan on receiving the amount of money based on the baseline for the current fiscal year times your percentage that you're currently receiving. So it should, to finish off the fiscal year in terms of budgeting. They are looking at a different allocation schedule for 16-17. They're trying to get feedback. The DHCS anticipates feedback from CBHDA and CSAC within the next couple of weeks, with the main goal of releasing a revised schedule prior to the first distribution of these funds in September. So again, you'll know prior to you receive your first amount of funding what the allocation schedule will be for 16-17. And then for the 14-15 behavioral health sub-account growth, you know, we know the number, although I don't remember it off the top of my head, but it's just sitting there at the state. They don't have a formal recommendation or schedule at this point on how to distribute those funds. But so at this point, I wouldn't anticipate any distribution until you know, until next fiscal year. So if you're including some 14-15 sub-account growth in your current year budget, you're probably definitely on a cash flow basis not going to get that. Maybe you might get lucky, and I wouldn't even say that. I don't even think you'll know the amount that you would get until we're into 16-17. Any questions on any of that stuff? All right. Some work group updates. So as we were told at the last meeting, CMS approved the fiscal state plan amendment that was submitted back in March of 2009. And the main thing that this does for you guys is give you the ability to claim through the supplemental claiming process for any costs, any Medi-Cal costs that you incurred above the schedule of maximum allowances, the SMAs. You'll be able to obtain FFP for those costs, depending on what the FMAP was during the service period. So it sounded like DHCS is pretty close to releasing those forms, hopefully the end of this month, which really is like the next week. This initial go-round will cover so when this became effective was January 1st, 2009. So this will cover the second half of 8-9, so that January 1st to June 30th, 2009, and then all of 9-10, because those cost reports have been settled with every county. They said don't, you know, even though the forms will be released and instructions, don't anticipate any payments until next fiscal year. And then the two other fiscal years where we still had SMAs that will be applicable to the supplemental payment program will be 10-11 and 11-12. Once those cost reports, I believe, have been settled for all counties, they will issue instructions on how to obtain the additional FFP for those costs. The other thing is that they are, I guess, working on an information notice around all of this, which also would relate to the whole customary charge and nominal fee provider status. They said that as part of the supplemental payment process that they would, or they're hoping to allow you to go back if you did not show that you were a nominal fee provider, that you would be able to go ahead that you did in fact meet the criteria to become a nominal fee provider. And what that does, where this really comes in is a lot of counties, because of the SMAs, you would set your published charge at the SMA level. Well, if all you do is eliminate the SMAs and you still go to the lower of costs or charges, your charges are basically the SMA, so you wouldn't have any additional reimbursement. However, if you show that you're a nominal fee provider, you're exempt from having to look at charges as part of the comparison. So this is kind of a critical piece for a lot of counties in terms of whether this supplemental payment program will be beneficial and result in any additional revenue or not. The one good thing that I think we heard is that at this point does not believe the 4 non-quantitative criteria that they require, which are basically that you have a published schedule of full charges, that your revenue is based on the full charges, that you have a written policy for write-offs when you charge less than the full charge, and then you've got sufficient documentation to support the write-offs. So those 4 criteria are in the cost report and are required to be met in order to qualify for the nominal fee provider status. What the state is now thinking is that those 4 criteria should not even be applied, which is great. So it would just be then going through and doing the calculation, which most of you should meet, if not all of you. I don't know why you wouldn't. And really, it comes down to what the provider reimbursement manual says at the federal level is that government providers that operate under a sliding fee charge schedule should not have to apply the lower cost or charges. And so this would be a way to get at that. And hopefully the state will go through with that, and it will result in additional reimbursement to everybody. But again, we'll find out more, hopefully pretty quick, hopefully even before the next meeting in May. So any questions on that? All right, so going into the other fiscal issues, the first one is what the question was brought up earlier. We reviewed, and again, so these are issues in county to county. We reviewed a letter that was drafted that would be from CBHDA to the Director of Mental Health Services over at DHCS, basically stating why you are not submitting revenue and expenditure reports, in that you need, the forms themselves need to allow for the proper reporting consistent with the information notice 11-15. I don't know what the status of that is. Hopefully it was submitted by CBHDA, but it'll be interesting to see what DHCS's response will be to that. We talked a little bit about Senate Bill 75 and why fiscal folks were not aware that this was going on in terms of the additional services to kids. And it sounded like the directors were informed. It just didn't trickle down to some of the fiscal folks in some of the counties. We talked a little bit again about the 2011-12 EPSDT. This relates back to Assembly Bill 100. If you remember, Assembly Bill 100 allowed the counties to decide how to allocate basically the MHSA funds that were redirected for EPSDT services in 11-12. And through that process, some counties were overpaid and others were underpaid. LA being the largest one that was underpaid, so they're actually owed quite a bit of money. But the issue that we have in trying to reconcile this and finalize it is that the state subsequently identified, because part of the 11-12 EPSDT payments included the settlement payments for 8-9, and the state had a gross error in their calculation of 8-9 settlement for the 12 counties that have hospitals, and it's over $9 million, and so we're not sure, how that's going to get resolved. But in any case, the 8-9 EPSDT settlement that was applied to the AB 100 distribution was not correct, and so that probably needs to get resolved before anything will happen with this. The other thing, just to give you guys heads up, and you've heard me talk about this before, the auditors, so as part of the AB 100, the 8-9 recoupments, so if you were owed money as part of the EPSDT settlement for 8-9, that occurred through the AB 100 distribution process. So if you owed money back to the state, then it was recouped through that process. What I'm subsequently finding is don't know that, and they will often try to recoup it again. So you really need to pay attention. And probably most of you are done with your 8-9 audits, so it's a moot point at this point. But you definitely did not want to get hit twice for the same recoupment. We talked about well, we didn't really talk too much about it, but there's CBHDA Financial Services Subcommittee Charter. It's posted on CBHDA's website. They are accepting changes to that, and there will be a vote next month to, I guess, move forward with the charter or changes or whatever you guys want to do, since it's your subcommittee. I talked already about the SAPD overpayments. The list was supposed to be presented to governing board for action. We talked a little bit about the Fiscal Leadership Institute, which is coming up the end of May. Registration is open. There was a flyer that is posted on CBHDA Financial Services Committee website, as well as you can always email Shoshana and she can get you information. Registration is open. It was brought up a little bit about what we're going to discuss. Day one is going to focus on the May revise from a policy perspective, as well as the Certified Community Behavioral Health Center, which is actually happening. The governor approved an appropriation to go ahead and develop the application, so that is moving forward. So we'll talk about that during day one. And day two, focus on drug Medi-Cal, and then the actual kind of the numbers from the May budget revise. So a little bit of an overview on what's going on with the Fiscal Institute. And then just to kind of give you an update, we didn't talk about this in the meeting, but just to give you an update, the annual adjustment that will be deposited this coming July, the state has calculated that, and originally it was estimated to be about $484 million. The actual number's $464 million, so it's about $20 million short. Really, I think it's the closest the state has ever been to their estimate and their actual. Usually it's off by more than 50%. So I thought this was good news. The other thing that's really good about it is that the number, the annual adjustment is fairly large. I don't know if you remember, we had about, I think it was a $94 million annual adjustment in the current year. So this is going to be significantly more funding for you folks in 16-17. The slight decrease, the $20 million, just to put it in perspective, would be about a 1% decline over the estimates that I presented to you folks back in February. So the estimates that I presented in February are pretty much pretty close to what we were expecting for 16-17 for MHSA at this point, which again is a huge increase over the current year. Taking a quick step back, since we have a couple of minutes, the current year MHSA is pretty much coming in as expected or as projected. So personal income taxes, they're running about 8% higher than in 14-15. You wouldn't see that in your overall Medi-Cal district or your MHSA distributions because of the annual adjustment. But really, the projections, again, that were provided back in February were right on track. But obviously, April collections with both last year tax returns as well as a quarterly estimated payment are very key. We still have 36% of the personal income tax payments to come in, which is typical. You know, again, with the April payments and collections, as well as June is an estimated month. So, but again, we're on target to hit it. So, if I was doing a budget, I would pretty much look back at what the projections were that we provided in February, and at least for 15-16 and 16-17, those are fairly good at this point. On little bit less of a bright note. Sales tax isn't coming in quite as well. We're pretty much, if you look at how much money you received to date for behavioral health sub-account, you compare current year to last year, it's pretty much, well, at least at the gross level, statewide, it's the same level of funding. And actually, since the percentages are the same, it should be the same pretty much within your county. So for both the behavioral health sub-account and 1991 realignment, it'll be interesting to see if there is, in fact, any growth above the base for the current year. So we've got a couple more minutes. That was it in terms of material I had. Are there any other questions on any of the county to county stuff or any other issues? Doesn't sound like.
Just you answered all the questions.
I guess so. All right, good. So again, we've got in 2 weeks the May meeting. Hopefully, a lot of you can attend or at least listen in. If nothing else, I think Don Kingdon talking about some of the Harvard findings will be interesting for you folks in terms of potential next steps on where the reimbursement system may go. I don't know how much we'll see BHCs as part of this meeting versus, again, a large chunk of the Fiscal Leadership Institute on May 23rd will be spent discussing that. And so it'll be really good to, hopefully a lot of you, if not all of you, will attend that. If nothing else, to hear that portion of it, because you're going to have to make a decision as to whether you want to participate. I believe a letter will be going out fairly soon to solicit interest from any counties that will want to participate in the CCBHC program. So, but yeah, that's it. So, Shoshana, anything else?
That's it for me.
Okay. All right. Thank you very much. Bye-bye.
Thanks, everyone. Bye.